Hello, my name is Jacqueline Muniz, and I am a DMP student at Palm Beach Atlantic University. Today I will be discussing a case study on sickle cell disease as it pertains to my current study of hemolytic anemias. The case study is as follows. The patient is a 15-year-old African-American boy who presents to the emergency department with severe abdominal pain. His mother informs you that these painful episodes began when he was about 1 year old. She also tells you that the patient, his brother, her husband, and she have been told they have the sickle gene. Only her husband has experienced similar painful episodes, pain crises, however. Physical examination reveals a soft abdomen and intact bowel sounds. The patient's pulse is rapid and his blood pressure is 125/90. His temperature is 98.8 degrees Fahrenheit. A complete blood count shows a hemoglobin of 8, white blood cells of 13,500, and platelet count of 350,000. Microscopic examination of the peripheral blood smear reveals red blood cell changes. In addition, there is significant polychromasia. Most of the white blood cells are neutrophils, segmented forms in bands. As described by Kumar, Abbas, and Astor, the major pathologic manifestations include chronic hemolysis, microvascular occlusions, and tissue damage. All of these manifestations stem from the tendency of hemoglobin S molecules to stack into polymers when deoxygenated. Initially, this process converts the red cell cytosol from a freely flowing liquid into a viscous gel. With continued deoxygenation, hemoglobin S molecules assemble into long needle-like fibers within red cells, producing a distorted sickle or holly leaf shape. The factors that affect the rate and degree of sickling include the interaction of hemoglobin S with the other types of hemoglobin in the cell, mean cell hemoglobin concentration, intracellular pH, and transit time of red cells through microvascular beds. Sickling causes cumulative damage to red cells through several mechanisms. As hemoglobin S polymers grow, they herniate through the membrane skeleton and protect from the cell and sheathed by only the lipid bilayer. This severe derangement in membrane structure causes the influx of calcium ions, which induce the cross-linking of membrane proteins and activate an ion channel that permits the efflux of potassium and water. With repeated episodes of sickling, red cells become increasingly dehydrated, dense, and rigid. Eventually, the most severely damaged cells are converted to end-stage, non-deformable, irreversibly sickled cells, which retain a sickle shape even when fully oxygenated. Sickle cell disease is a classic inherited disorder of a nucleotide mutation causing a single amino acid substitution from glutamic acid to valine at position 6 on the beta-globin subunit. The substitution leads to changes in the physical properties of the globin chain. In regards to genetics, a recent study by Lim, Fast, and Morris indicated that the intestinal microbiota is responsible for regulating the number of age neutrophils, a subset of neutrophils that are overly activated. Reduction of these neutrophils in vivo protected the mice from fatal TNF-induced vaso-occlusive crisis. Researchers discussed the reasons why patients with sickle cell disease may have an abnormal intestinal microbiota and how this could contribute to the development of vaso-occlusive crisis. In a mouse model study by researchers of vaso-occlusive crisis, instead of attaching to endothelium, sickle erythrocytes more commonly adhered to activated neutrophils. Sickle cell disease patients have higher levels of soluble CD62L, a serum marker of neutrophil activation. Neutrophils from sickle cell disease patients also express higher levels of activated molecules that mediate their adherence to endothelium. These immobilized neutrophils may act as a site of origin for sickle erythrocytes to attach and to cause vaso-occlusive crisis. As far as diagnosis, Kumar, Abbas, and Astor discussed the diagnostic process by explaining that diagnosis is suggested by the clinical findings in the presence of irreversibly sickled red cells and is confirmed by various tests for sickle hemoglobin. In general, these involve mixing a blood sample with an oxygen-consuming reagent, such as metabisfolite, which induces sickling of red cells if hemoglobin S is present. Hemoglobin electrophoresis is also used to demonstrate the presence of hemoglobin S and exclude other sickle syndromes such as hemoglobin SC disease. Prenatal diagnosis is possible by analysis of fetal DNA obtained by amniocentesis or chorionic biopsy. In a study conducted by Al-Hamoud, Zurich, Al-Faris, Maraf, and Al-Mulla, researchers investigated plasma cell-free DNA concentrations in sickle cell disease patients and aimed at exploring the significance of plasma cell-free DNA as a potential biomarker in predicting its complications. Plasma cell-free DNA levels were measured using real-time quantitative polymerase chain reaction to quantitatively measure beta-globin gene in blood samples from 57 sickle cell disease patients with acute vaso-occlusive crisis, 42 patients in steady state, 16 individuals with sickle cell trait, and 40 healthy controls. Plasma cell-free DNA level was significantly elevated in samples from patients with acute vaso-occlusive crisis when compared with those in steady state, and was significantly higher in both in crisis and in steady state when compared with individuals with sickle cell trait and healthy controls. The data suggests that plasma cell-free DNA may be used as a tool to diagnose and monitor the sickle cell crisis and differentiate post-packed red cell transfusion sickle cell disease patients from individuals with sickle cell trait. Kumar, Abbas, and Astor explain that sickle cell disease causes a moderately severe hemolytic anemia that is associated with reticulocytosis, hyperbilirubinemia, and the presence of irreversibly sickled cells. Its course is punctuated by a variety of crises. Vaso-occlusive crises, also called pain crises, are episodes of hypoxic injury and infarction that cause severe pain in the affected region. Although infection, dehydration, and acidosis can act as triggers, in most instances no predisposing cause is identified. The most commonly involved sites are the bones, lungs, liver, brain, spleen, and penis. Kumar, Abbas, and Astor describe treatment options for sickle cell disease. The text states a mainstay of treatment is an inhibitor of DNA synthesis, hydroxyurea, which has several beneficial effects. These include an increase in red cell hemoglobin F levels, which occurs by unknown mechanisms, and an anti-inflammatory effect, which stems from an inhibition of leukocyte production. These activities are believed to act in concert to decrease crises related to vascular occlusions in both children and adults. Hematopoietic stem cell transplantation offers a chance at cure and is increasingly being explored as a therapeutic option. Other forms of treatment include pharmacologic and non-pharmacologic pain management in times of pain crises, in addition to blood transfusions and exchange transfusions as needed. A recent study conducted in 2017 by Riebel et al. Described a new form of treatment and possible cure for sickle cell disease besides allogenic hematopoietic stem cell transplantation. In this study, a boy with sickle cell disease diagnosed at birth was enrolled in a clinical trial in May 2014. At 13 years of age, the boy received an infusion of the drug product lentiglobin BB305, a self-activating lentiviral vector. This is described as a therapeutic gene transfer into autologous hematopoietic stem cells. After completion of treatment, the boy had complete clinical remission with correction of hemolysis and biologic hallmarks of the disease. This concludes this presentation on sickle cell disease. Thank you.